Hello, all. This is Dr. Dheeraj Masapu, and today I'm going to talk about how healthcare disruption can happen in future and how the healthcare is going to change in the next 5 to 10 years with the technologies which are going to come up, which includes the AI predominantly and robots and telemedicine and also the augmented and virtual realities. So for this, I'm interviewing Dr. Massimo Lamberti, who is the head of anesthesia in Cleveland Clinic, Abu Dhabi, and he's been with technology since long time, and he's passionate about technology, and he's going to tell us how the technology is going to change the healthcare in future. And don't think that this is going to take decades to happen. And with the AI and technology, things might happen in months and years only. If you don't adopt to what he's telling now, you might be lagging behind, and you will be replaced by either AI or a person who is actually using AI. Okay, so please follow the particular video, and every line that we are going to discuss is going to help you significantly in building your career in future. Thank you. We have Dr. Massimo Lamberti, who is the chair of anesthesia, Cleveland Clinic Hospital, Abu Dhabi. Welcome to the channel, Dr. Massimo.
Thank you very much for the invitation. That I don't have any conflict of interest on my presentation. I'm just a technology passionate since when I was very young. I believe was one of the first buying the Commodore 6064 years ago. I will start first of all with this first big topic that is presenting in our reality is related to the telehealth. So there are already realities, especially in the United States, where telehealth is a reality, not only because it's allowing the patient to have a teleconsultation, but telehealth is very present even in the ICUs. The Cleveland Clinic system, for example, has one very successful system where the anesthesiologist can simultaneously have a link with patients with cameras that are mainly following the patient during the ICU journey. And there is even one more advanced way to use telehealth that is related to the teleconsultation for the pre-anesthesia visit. This is something that we even do here. Actually, there are different systems from the simple Zoom, the one that we are using, to Teams or other tools that can easily allow the telecommunication, avoiding patient to go and even do expensive trips all around. I believe that the advantage of the telehealth is the fact that it is reducing the time that is even for the social cost that the patient had in the past, and even the hidden cost that, for example, the physician had to move from room to room to see patients during, for example, their ICU stay. The telehealth, for example, for us was very helpful during the COVID because we could see inside the room what was happening even without entering the room. As many of us remember, the COVID time was very tough, and having the PPEs all the day was very stressful. And the telehealth was the first example on how to assess patients inside and outside the hospital. We had multiple occasions, and we even fine-tune the tweaks that you have with the telehealth where you don't have the so-called human touch, but you can still use other ways because we are not bots, and so we can put our anesthesia and intensive care touch in this feeling with the patient.
Okay, got it. So now I understood that OTs also you can monitor, an intensive care. Main usage is an intensive care unit to monitor the patient distantly. And also during
there are even in Australia, for example, there was a first example of tele anesthesia where one anesthesiologist was remotely, and when I say remotely, the distance was more than 500 kilometers, was remotely managing 3 multiple ORs that were managed by a nurse anesthetist in a remote area of Australia, doing simple procedures. And this was the first example where one anesthesiologist was able to manage a simple procedure outside. I don't know if this is the future, if this can be considered completely safe, but in that case, it was successful, and with some precautions, the anesthesiologist could manage with telehealth just the tele monitoring of those procedures.
Understood. It has a role surely because, for example, we are neuroanesthesiologists, and in a town or a tier two city, some aneurysm clipping is happening, and we can't go there. We can give suggestions to them at different phases on what kind of blood pressures need to be done and what kind of perfusion pressures they need to maintain. All these advices we can give remotely. And if crisis happens, we can give them suggestions on how to actually manage that. In that way, we can improve the quality of care and safety.
Yeah, I believe so. The advantage of the telehealth is to reduce the distance and to reduce the time. With even different time zones, we can reach easily other colleagues all around. There are even examples of 24/7 tele ICUs. For example, the John Hopkins Group has already done this remotely, managing different ICUs even outside the United States, having a 24/7 telehealth telehub that is servicing patients even in remote areas where they provide the service. So with the telemonitoring, it's possible to have all the images and the information in real time for a patient. The second part that I want to discuss with you is the data-driven decisions. So everyone is talking about big data. There are even big data conferences where we are trying to put all together the data to drive evidence-based decision. There are, for those who are more familiar with artificial intelligence, different tools that we can use. So I remember when I started studying, there was just the simple Bonferroni analysis. It was only a kind of regression model, and now we are using more advanced ways to have directly the computer to have an output through the data that we are giving. The problem, as usually, is garbage in, garbage out, and is more derived on the local population, because it's essential, especially when, for example, we are analyzing images. The images are clearly defined by the local population, the local characteristic of the population. And if we are just trying to buy something that can be applicable, this doesn't happen. So the data-driven decision is also has to be properly used. For example, if we have great results, and this is happening, for example, now in many of the tools that we use in anesthesia or even in ICU. I give you an example. Hypotension prediction has a gray area where we don't know if we are really able to predict the hypotension of the patient, if the patient can be in ICU or in the OR. That's why there is still an essential part from the clinician to understand to what extent this data can be reliable in our practice.
Oh, excellent. This is a very good tool because in day-to-day practice for me also, even some cervical myelopathy patient for lateral mass fusion, when we turn prone, some will get hypotension, some do not get. So if you have some kind of a technology which can predict before, so this particular patient can develop hypotension based on some parameters, it would be helpful. We'll be more vigilant in those cases. So this is exactly you're telling, right?
I give you a simple assumption. Hypotension is not good at all for anyone. So, and as you said, so one size doesn't fit for all, because some patients are not, some patients are developing hypotension. And for us, having a tool that can predict and can counteract the hypotension can be beneficial. For example, if you are using IOM and you have hypotension, you lose the signal, and then you have to increase the blood pressure. It can be even time consuming. For sure, having tools that are driving our decision. For example, if I have a patient who can develop sepsis and we knew in advance, even 12 hours in advance, I will start putting in place all the potential tools and the misses that we have in our mainly in our army to prevent the possible complication of sepsis, starting from the antibiotic to even an aggressive volume resuscitation and starting even with vasopressor. But for sure, so there are data that are not clear, and that's why, or are mainly delayed, and that's why we need to have more precise data. And precision medicine is not that data-driven medicine. Precision medicine is still something that is far from our clinical practice. Is more related to cancer treatment and still not really applicable to the area of the critical care that we are practicing.
I understood. Precision medicine is more on genetic analysis, and that it will be more pharmacogenetics will apply for oncology mainly.
Yeah.
For us, we need a clean and neat data to come to some conclusions. That is what you're telling.
Yes, and especially we have not yet reached a very quick conclusion. For example, we have in precision medicine, in anesthesia, for example, some tools that can predict if the patient is sensitive or not to opioids, but still is part of more a research program than what we can do in daily practice to the patients. Or if a patient is more susceptible to have hypo or hyperglycemia, there are some genetic markers that can give us this information, but they are still far from the clinical practice. So one other topic that I want to discuss is the use of artificial intelligence and the robots. So when they asked me recently how far are we to be substituted by artificial intelligence robots, I say maybe I will be retired by that time. So I'm not saying that it's going to not to be applicable to us. So we have many tools. For example, I'm going to have a new ultrasound that can mainly measure the ejection fraction of the patient with the TE or even the TOE. Is amazing, or there is even one tool that can predict the difficult airway of the patient just with a facial recognition. These are tools that are, let's say, now becoming more commercially available with even application you can have on your phone. The problem is how you can then define, let's say, and go back to a patient who can develop sepsis, if this patient will develop hypotension within 1 day, 1 hour, or 1 minute. This is still something that is not there. And the same for the robots. So we are using robots mainly daily. We have PK pumps that can deliver anesthesia, or we have, again, artificial intelligence that can tell us if the patient has a too deep anesthesia or not. But still, there is a lack of communication, because the pumps are giving us the concentration of the drug in the blood. But then they are not capable to integrate all this information, and then it's more a zigzag system where if it's too much, it stops, if it's too little, it's giving. So it's still not able to provide the entire spectrum of mainly actions that the human being is able to do. So this multitasking that is more related to the human being is still not there. And sometimes the problem of the artificial intelligence that is following a logic. Sometimes human beings are illogical, but sometimes being illogical is creating the solution. While a system and an artificial intelligence, by definition, has to follow a logic. Even the fuzzy logic, that is one of the systems used by artificial intelligence, is still following a clear logic. While sometimes humans, maybe because they do mistakes, they are illogical. The second part regarding the robots is I would like to have someone substituting me intubating. Still not possible. And one of the reasons for those who are interested in Elon Musk is the robot that he presented recently. because the robots they have very slow movements that are limited by the electricity that they have to use, and the second is the use of the thumb, so they are not able to use the 5 fingers as human beings. For this reason, their movements and their coordination is very slow. And there was a very old now video that was done by Professor Schaeffer, who was the past director of Palo Alto, who was showing how fast was an anesthesiologist preparing drugs and intubating the patient, and how slow was the same robot just folding a towel. So that's why, if you will ask me, I honestly believe that it will take another 20 years to have robots who can really support us in the healthcare and in our job.
Got it. So to summarize, what you are trying to tell is this artificial intelligence and robots might help us in doing all the paperwork, maybe doing the paperwork, notes, charting, and those things it can do efficiently and accurately. And we can focus
Yes.
more on our clinical work. And
Yeah, there are already even environmental system that can capture what we say to the patient, what the patient says to us, and they are just merely very good artificial scribes. And they can even correct or put in notes what was the conversation, for example, even the informed consent or even the HMP that is coming from a patient. They are still not capable to put this information in a way to diagnose and to put a final treatment to the patient. They propose a treatment, but they are not still capable to take the final decision.
maybe they will propose a treatment and we have to confirm.
Yeah. Yes.
Because even humans can miss few things. They will help us in getting all the things, and we can finally confirm it with our experience and skills. I think so.
Yeah, this is what I call artificial intelligence assisted medicine. And this is bringing to my fourth point that is already here. Google Health and Health from Apple are clear examples on how we can mainly protect ourselves. Google Health is mainly managed by the best professionals. Akio Waganda, who is the inventor of the WHO surgical checklist, our past chair of the Cleveland Clinic, Toby Crossgrove, are part of Google Health, and Google is trying to attract the best talents to understand how to improve the alternative care as I define in the future. So health is more an application that we can use with a simple watch that can detect if we are having a kind of strange arrhythmia and can call 911 and can save our life. These are the starting points, but they are already quite evoluted. And especially Google Health is already able to provide with good estimation, possible differential diagnosis in a patient who has some symptoms. And just Googling the symptom, the patient can already by himself mainly search for an appointment to a dermatologist or to someone else. The evolution is, again, the integration of all this information with the telemedicine. That so is a kind of multi-tool analysis that the artificial intelligence plus the telemedicine plus the wearable devices can provide as support again to our job. For example, in our hospital, we are trying to have wearable watches where the patient can wear the watch and you have already pulse oximetry, you have heart rate, the cardiac rhythm. You can understand if the patient can, for example, afford to have a surgery according to the effort that is taking just walking for 100 meters in the hospital.
Got it, got it. I understood. Basically, what you're trying to tell is the telemedicine, artificial intelligence, and the all the softwares are trying to integrate and work together. That is what is going to happen in the future.
Yes, and that's why even there is a big competition between the new the all these high tech companies, not only Google, but even those who are creating the hardware to allow the final user to have a product that can be considered cheap and in the same time is mainly reliable, because you can have even a watch but doesn't work, and so the product has to be with a very good cost efficacy, so to be cheap and effective.
Got it. Maybe patient can have a watch when he comes for a PAC, you get all the data, and between your PAC and surgery, lag period also, you can maybe get his recordings and
Yeah,
maybe.
there is a. I give you an example. There was a recent publication in one European journal regarding the use of the Fitbit that was given to the patient, especially those who were having VATS surgery. They were discharged home and they used the Fitbit to send the data to the telemedicine in the hospital to understand if the patient could develop AFib, for example, or was desaturating. And in this way, there was an alert immediately for the patient. They used this system and they saw that the readmission of the patient was really minimal. And because they had some discharge criteria and then discharged the patient with this simple watch, the watch was mainly avoiding an avoidable admission in the hospital.
Excellent. I'm
Yeah.
very amazed. Yeah.
Yeah, my last point is for the future trainees. So we have honestly less and less time to teach them. So that's why the virtual reality and the augmented reality can not only reduce the distances between any place where the teacher and the trainee is learning, but the virtual reality can create even environments that can be useful just to train the trainees. Can be for different scenarios, from a shock room where you have a trauma patient coming and to measure mainly your reactiveness to an event, can be hypotension or bleeding, even to even implement the tools that and even the skills that the trainee is having. Now we are in the era of ultrasound or video laryngoscopy, so everything is more virtual than it was before. And even if there is a kind of resistance from some of our colleagues to use these tools, this is the new reality. So I'm not saying that we should not stop teaching the traditional anatomy, the landmarks. Yes, possibly this is something that has to be used as a rescue, but the daily practice is now in this direction, to use more and more ultrasound, to use more and more the technology as the only alternative to even reduce our time spent with the patient, because we have less and less time that we can spend. So that's my final comment to this point, because if you don't use the technology, you will need more human resources, and human resources at this time are less and less in worldwide. So it's not just Europe, India, or Middle East. Worldwide, we have a deficiency of healthcare providers. So, yeah, tell me.
To summarize, we have to use all the technology what you told till now, so that they can be an adjunct to our skills, and we can provide high quality care to more number of people. That is what you're trying to say.
Yeah, just to give you an example, in the month of March, we trained some trainees in Cleveland with the virtual reality staying here. So when we were in the same virtual room simulating a shock, an hypovolemic shock, and there and here we were wearing goggles. and we were doing the simulation at 9 hours time difference. So this is possible, and is avoiding so the trainees to move, or the teacher to move, and probably this is now going to be the new reality.
Excellent. So, future of education will become more practical oriented with the augmented reality and virtual reality, AR and VR.
Yes.
And the availability of these devices also will increase, and the cost of the devices also should come down a little so that it will be accessible to many people.
So my last 2 points are related to the pro of the technology that again can personalize the care, create a fast access, and create more predictable outcomes. The cons are related to the possibility, as now in today are discussing the G7 group, on the possibility of the use of the artificial intelligence, the so-called cyber fraud, and even the education. So I like one Indian term that is translated as disruptive education, and this disruptive education means that we have to change a little bit the traditional way we are educating our future trainees. So even ourselves, so going in a year where the future trainees will be trained on iPad or other mainly virtual tools, is going to change even the education and even the expectation that we have from these trainees in the future. Most probably the information will be given through an artificial intelligence. So the way we will have to teach our future medical students is even how to interpret this information that is coming from the artificial intelligence, how reliable is the information. Because nowadays everything is virtual, and we don't have any more physical books, and we need to understand how to interpret this information in the future. So I believe as educator, our job is going to be tough for the next 20 years, because we have even to re-educate ourselves in a way we educate our trainees and medical students.
So basically, textbooks are gone and now online books. In future, I think online books also will go and everything will be a central AI database. So if you want to read about something in AI, it will form. If you ask anesthesia for suprarenal brain tumors, then it will make a chapter for you. It will give you all scenarios, and then it will send you all the videos. At the end, it will conduct a small test for you. Maybe the whole system of education might change in 10 years down the line. So
As you mentioned, for example, we have now even consensus. There is a recent one that has been published on the optic nerve sheet. That is one of the topics that I mainly discovered years ago. And now we are finally coming to a consensus, but it's still a group of people, and there should be a discretional interpretation on what is done in a consensus, because it's not evidence-based. So, and the information that is coming then from the virtual books or even the digital intelligence has to be interpreted according to our clinical scenario. So we cannot, again, use one size for all. So we have to adapt to a single patient the information that we are going to receive from the artificial intelligence.
got it. Maybe artificial in among the research articles also. I know some of the research articles are clean and good, and some are like not very clean. So AI should have some kind of a technology where it filters and gets you the best articles or something like that. Will be done in future surely. So these kind of things will.
Yeah.
So then, superb. We discussed many new things, and so how do you want to give any concluding comments, Dr. Massimo, like for the students, how to actually plan their career? And
So there is for sure a very fascinating world that we are going to have in the next 50 years. I believe the advantage of this new technology has not been taken as a possible competitor. We just, as I say, have to use this tool. So it's the human touch that we are having with every patient every day is not going to disappear. But so we have to use these new tools in a way to facilitate our job. So having them as an assistant that can be faster and can really easy our job and drive us to a clear clinical conclusion to a patient. The use of the robots probably is going to be will take longer, but even for those, we should not be mainly skeptical on the use. I was very skeptical in the beginning when the video laryngoscopy was created, and now I'm one of the best user. I use this since probably 20 years, and honestly, I will never give up to the video. So that's why the message is don't be scared. Just use with your human touch the new technology.
So we have to adapt faster. That is what you're trying to tell.
Yes, very fast.
Very fast. And unfortunately, in doctors, what I'm seeing is there is a lag of 5 to 6 years. Like some centers are different, like your centers, but other centers there is a lag of 5 years. Some centers actually they don't even know what is happening in other parts of the world. So I think everyone should get updated and use AI to actually, beat the AI. Something like that we have to do.
But for example, your channel is a clear example on how we can disrupt the education. So now is plenty of videos in YouTube, and YouTube honestly is not the right platform because the videos can be good or not. There is not a judgment on how the video is done. But honestly, it's better to have a video than not to have a video. That's my thought. And even if it's not perfect, it can still be useful for those who are not cannot use a technology to approach to the new technology. So YouTube for sure is a technology that has unlimited resources, and we have to use them as much as possible.
Thank you very much. Thank you all, and our audience will put their comments in the comment section. And I really like the term disruptive education. I'll give that as my title for this disruptive education with the help of AI and other things. This is how the future is going to be. So thank you, Dr. Massimo. Thank you for coming.
Thank you very much.
Thank you very much.